All right, good evening, everyone. I want to welcome you to our presentation tonight. We're going to start in just a couple of minutes to let our guests log in. Well, to respect people's time, I think we'll get things started. So I'd like to welcome everyone this evening. My name is Chris Malloy. I'm a certified financial planner and senior advisor at TMFD Financial. I'd like to start off by thanking you for joining the webinar this evening titled Endodontic Diagnostic Protocols. In a moment, I'll introduce our speaker, Dr. Gary Glassman. But first, I'd like to introduce TMFD Financial and explain the valuable services we provide to clients. Our goal is to make the financial lives of our dentists simpler by combining a variety of services under one roof, from tax, investments, insurance, and other financial planning matters you may have. In our experience, we found that providing a one-stop shop for financial solutions provides clients with the comfort of knowing that all aspects of their financial careers are synchronized. The result is simplicity, peace of mind, and confidence in your financial decisions. For those new to TMFD, I wanted to mention a couple of offers that might be of interest. For practice owners, we have the Dental Practice Assessment and Financial Review. This process highlights the financial health of your practice, identifies areas of excellence and areas for improvement, as well as an estimated value of the practice. This is a service we offer to all our existing clients, so if this is of interest, feel free to contact us. And for associates looking to purchase a practice, we help guide you through the process. This includes a review of the practice cash flow and loan repayment projections, as well as identifying areas of strength and potential areas of concern with the practice. More details about both offers will be provided in an email following this presentation. So at this point, I'd like to hand things over to my colleague, Jake Giesler, who's managing the technology for us, and to provide some housekeeping items.
Thanks so much, Chris. Good evening, everyone, and welcome to the TMFD Dental Academy. Thank you so much for joining us this evening. As Chris mentioned, my name is Jake Giesler, and I'm also a financial advisor from our TMFD financial team, and I'll be running the technology in the background this evening. But before we get started, I just want to take a moment to run through these housekeeping items. So the webinar is scheduled to go until about 9 p.m., and if you have any questions for Dr. Glassman during the presentation, please ask them in the Q&A section at the bottom of your screen, and they will be answered at the end of the presentation. If you have any questions for me behind the scenes or something you'd just like to comment, please feel free to send a chat in the chat box. CE credits will be sent out within 2 weeks, with no later being October 18th. Lastly, we encourage you to register for our TMFD Dental Academy mailing list so you can stay up to date with all our future webinars. That's all I have for the housekeeping items for today. So Chris, I'll throw it back to you.
All right, that's great, Jake. Thank you. So now I'm very pleased and excited to introduce our speaker this evening, Dr. Gary Glassman. Dr. Glassman completed his dental degree at the University of Toronto in 1984 and then graduated from the Endodontic program at Temple University in 87. Dr. Glassman has won numerous awards, including the Award of Merit from the ODA for his exceptional contributions to the field of dentistry earlier this year. Dr. Glassman has authored numerous publications, he lectures globally, and is on staff at the U of T. So I think we're in very good hands this evening. In the time I've gotten to know Dr. Glassman, it's clear he very much enjoys teaching and creating awareness about proper case diagnosis so that it integrates well with the patient's overall health plan. So Dr. Glassman, from all of us here at TMFD, we'd like to thank you for your participation. And I'll turn things over to you now.
Thanks, Chris. I'm going to share my screen. I see that Dr. Imran Khan is on, asked me a question, and just want to do a shout out to Dr. Khan. Hey, Imran. And thanks for the compliment that I look so young. How can I graduate in 1984? Yeah. Well, I graduated when I was 12, Imran, so that's the big secret. All right, so let's get going. And tonight I want to talk about, I want to get rid of this. Systematic diagnostic protocol. I think this has sort of been the missing link, the sort of missing piece of the puzzle that we really don't get when we're in dental school. We learn how to do endo, we learn how to do perio, we learn how to do all the disciplines, treatment planning is something that we just, have to sort of had to tie together on our own. And I want to take you through a protocol that I go through with every single tooth that comes into my office, every single patient, if they present in pain or they don't present in pain, if they're referred to me to look at their, root canal status. Whether it's an obvious problem or something that's a little bit less obvious, I still go through the same protocol because I don't want to miss anything. And that's the big thing that you do not want to do. You don't want to miss anything. And you want to compare things to, what's normal in that particular patient. And then you do your clinical tests, make sure you interview the patient properly, and they take you through all that, and then come to a diagnosis. So missing piece of the puzzle, and patients often come in, sometimes it's obvious, they can point to a tooth, they just had a filling done on a lower first premolar, and ever since then it's been bothering them, and it's pretty obvious where the problem is. But sometimes they come in where they have, pain starts up here and it ends up down here, and then you're in for sort of a diagnostic dilemma where you really have to go through all your steps and not skip any steps. So when a patient comes in, we're really going on a reconnaissance mission. We're trying to gather as much information as we possibly can to come to a proper diagnosis. And I picked up a really great book, and I think you should all read it. It's called The Checklist Manifesto. And just like a pilot goes through his pre-flight checklist, we have to go through our checklist as well. And we can't skip steps, because when we skip steps, we could miss something, we could misdiagnose, and we're not doing the patient much of a service. So it's through intuition and being in this business, practicing as an endodontist for 37 years and dentist for 40 years, you learn a thing or two about a thing or two, and you get a certain intuition, you get some clinical experience, and through that, probably about 85% of all endodontic diagnosis can be made by just listening to the patient. And that's really important. We're very quick to put our patients back and start tapping on teeth without first having them share what their problem is. In fact, it's interesting. This is an interesting fact. Fun fact is that probably takes about 8 to 10 seconds on average when someone is talking to you before you actually interrupt them and share your opinion and share your views. It takes a lot of restraint just to hang back, keep it zipped, and listen to the patient, because there's so much information that you can get from that patient just by listening and going through our checklist, interviewing the patient, asking them what their chief complaint is in their own words, and then going through the list. Is it sensitive to hot? Is it sensitive to cold? When did it start? And we'll go all through all those in a few moments, but we don't want to skip steps. So these are the questions that we'll often ask the patient. And often they'll just share this with us because it's important for them to get it off their chest and let us know how they're feeling. And they're very scared. They're very nervous. Most patients are. The dentist is, has the reputation of being, a painful experience, but we assure the patient it's not going to be, and we're here to help them. And that's the most important part. As soon as patients come down, I'm Dr. Glassman, and me and my assistant are here to help you. And these are all the questions. These are important questions that you either have to ask them or have them share with you, especially when you're screening for emergencies. And we're going to take you through some emergencies as well today, how we handle the most common endodontic emergencies, that being an irreversible pulpitis, with or without apical periodontitis, or acute alveolar abscess, with or without swelling. So these are important things. So when we triage for emergencies, we often say, how long have you been in pain for? Well, I've been in pain for 3 weeks. That's not an emergency. I woke up, I'm in pain, I can't eat, I can't sleep, I can't go to work. That's an emergency. I'm bleeding, I have pain, I have swelling, I have difficulty swallowing or breathing. That's an emergency that needs to be sent to the hospital. So these are all things that we can get even just by the phone call when they call our office. But these are the things that we need to ask the patient. Having a proper medical history is important because they may be on medications that may affect the treatment and may affect your decision-making process. For instance, a lot of patients now are on anti-resorptive medications, and we need to know if they're on these medications and, of course, other medications, of course. But the anti-resorptive medications interfere with bone metabolism. Patients are on them for osteoporosis. Sometimes they're on them for cancer treatment and other maladies as well. And it's important that we know if they're on that, because extraction is not really an option in a lot of these patients, because they could end up with a medical related to osteonecrosis of the jaw. So we want to take a medical history. We want to know their allergies. We want to know if they're on any neurological medications, and that will give us a hint if they have a neuralgia or other conditions that may actually cause facial pain. And we go by the mnemonic of SOAP, SOAP, which means we gather the subjective information. That's the interview, that we have the patient in the chair and we have them share their information. We restrain ourselves from talking and we listen to them. The objective information is the clinical exam. That's after we've exhausted all the information coming from the patient and sort of putting them back in mainstream and making sure that they don't go off on a tangent and start talking about their weekend and their dog, etc., and they sort of stick to the task at hand. Then we put them back. We do our clinical tests, our radiographic, our imaging that we have to do, whether it's just a PA or whether it happens to be a Panorex or a cone beam. Then we take all that information, we assess it, and then we plan for treatment. So what's the subjective information? This is basically the information that we need to get from the patient so we understand perhaps where that pain is coming from, the frequency of it, the severity of it. What relieves it? Is it ibuprofen or is it a morphine drip? Does it hurt all the time? Does it come in waves? Is it stimulated by something? So these are all clues that we can get in order to try to make a proper diagnosis. Now, when we gather the objective information, the first thing we do is we look at the patient. We look for any asymmetries. We look to see if they are swollen. We'll look to see if they have a goiter, perhaps. So that's important. Then we do our clinical testing and then radiographic evaluation. And with that, once we assess it, there is no ideal classification for pulp and periapical disease. Unless you're going to take a histological section and look at it underneath a microscope, we're making our decisions and our classification based on clinical and radiographic findings. And we make a dual diagnosis. We make a diagnosis, a pulpal diagnosis, and we make a periradicular diagnosis. And that's really, really important. We'll take you through the American Association of Endodontic nomenclature for that dual diagnosis. And when we do our diagnostic tests, we're merely trying to reproduce the patient's symptoms. We don't want to hurt the patient, but we want to reproduce the patient's symptoms so we can understand exactly what they're feeling. Now, some patients, for instance, are sensitive to cold in all their teeth. So we need to know what a baseline is for that patient. So when I start doing my sensitivity test or my periapical test, what I want to do is I want to start on a normal tooth or teeth that I know are gonna give me a normal response, like a virgin tooth that's never had a filling, never had a cavity, never had a crack. So I want to see what's normal for that patient. And I use the word normal a lot before I start doing my testing. Mrs. Smith, I'm going to test a normal tooth, because a lot of times they're scared. They have cold sensitivity. They don't want to see you coming at them with an ice stick or some endo ice. And if they do, we want them to make a reliable response. So I'm going to have Mrs. Smith lying back in the chair, and I'm going to say I'm going to touch a normal tooth with a little bit of cold. I want to see what normal feels like, and I mentioned normal a million times. So now they're laid back in the chair, and I know they're going to give me a reliable response when I actually zero in on the suspected tooth. So first thing we're going to do is our pulp sensitivity tests, and I like the cold test, the thermal test. It's very, very reliable, and it stimulates the A delta nerve fibers. These nerve fibers are very, very fast acting, and I know I'm going to get a response in most cases, and it's going to be immediate, and it's going to resolve very quickly. It's a normal response, and I'll start on a normal tooth. What isn't a normal response is when it replicates the symptoms that they're experiencing, and that's what we're trying to get after. So I like to use ice. I like ice. Ice stimulates the A delta nerve fibers, and ice is familiar to the patient. right? So I like to use that most of the time. I think it's important that patient is comfortable. And how do we make our ice sticks? Well, very easy. We take the plastic covers from the needles. Once we've disposed of the needles, we fill up each piece, each end with some water. We put them together real fast. We stand them up in a plastic cup and we put it in the freezer. Then when we're ready to do the test, my assistant will go to the freezer. She'll get usually 2 ice sticks because sometimes one melts or breaks. So, and she'll rub it between her gloved fingers, which will melt the outer layer of the ice stick, and she'll pull off one, or sometimes she'll pull out the other one with a 2x2. And as you can see, we test each tooth and look at her eyes. She can feel that discomfort. It's always in the eyes. And we ask the patient, yes or no, do you feel the cold? We don't want an essay answer. We don't want them to give us a dialogue about it. I just want to know yes or no, do you feel the cold? And hopefully they do. Now, some like to use endo ice. That's not my preference, although many of my colleagues like it. I find endo ice saturates, it's a refrigerant. It saturates these cotton pellets really, really quickly. So you get to one tooth and you got to switch cotton pellets and go to another tooth. So in my opinion, it takes a lot of time. In addition, when a patient is nervous and they're scared, they're sitting back in your chair and all of a sudden they see this puff of smoke in front of their face. And if they haven't, ran for the door, they're going to bolt right out of your chair right there and then. So we want to make the patient feel comfortable. But if you're going to use endo ice, spray it, get to that tooth really, really quickly and see if you can, again, replicate, the patient's symptoms. And quite often after the second tooth, we have to go and use a new cotton pellet because it gets hard, it gets saturated, it doesn't absorb the refrigerant. So cold is a good one. And then there's a hot test. I don't rarely do a hot test, but a hot response often will indicate a necrotic pulp or a pulp that is degenerating and not sensitive to cold, but sometimes when they have their hot tea or coffee or soup, they get that discomfort. And historically, there have been a lot of things that were used. I definitely don't use a hot gutta percha nor a hot ball burnisher heated up on a Bunsen burner. Hot water is a little inaccurate. You have to isolate each tooth. It takes a lot of time to do it, and the water cools down to body temperature really quickly. One of my partners uses a Profi cup to generate some heat, but he's got a lot of experience, and I don't recommend it because it's really not that accurate, and it's hard to get that. And actually, you can actually fry pulps by doing a hot test inaccurately. So I would probably stay away from that. What I do use is something called the hot pulp test tip. System B hot pulp test tip by Cavo Kerr. Dentsply Sirona also has ones that goes in their Gutta Smart or their Calamus. Cavo Kerr has one that goes in their System B or their Touch and Heat. So different companies have different ones. And that's the one I use. It stimulates the deep sea nerve fibers. And when you stimulate the deep sea nerve fibers, it's a delayed response. So I'm not going to keep that piece of gutta percha that's being warmed up by the hot pulp test tip on there till the patient feels it, because once they feel it, it's going to escalate and really be quite uncomfortable. So I put it on the tooth for a count of 1, 1,000, 2, 1,000, 3, 1,000, take it off, and I wait. But you got to be really careful, as I mentioned, with heat, because you can actually put too much heat on a tooth for too long and cause irreversible changes in the pulp. So you can take a normal pulp, and if you increase the temperature due to an improper heat test, you can actually throw that tooth into an irreversible pulpitis, and a 20°C rise in the pulpal temperature can actually cause that normal pulp to be necrotic. So you have to be very careful with it. So this is the hot pulp test tip from Cavo Kerr, and you place a piece of gutta percha in there, and then you activate it, and it goes through that insulating sleeve, that little black sleeve that you see. And when it gets to the gutta percha, it heats it up to around, well, I'm Canadian, 57°C, and but the temperature of a hot cup of coffee. And you want to use a separating medium on the tooth. It's really, really important. Separating medium is key because you want to be able to remove it. And if you can't remove it and it heats up, you're frantically trying to scrape it off. Sort of like that, the hot onion or the pizza cheese that gets caught on the palate. You're trying to frantically get that off. So I put a little bit of separating medium on there and put that on top of the tooth, and I activate it. Like I said, 1, 1,000, 2, 1,000, 3, 1,000. I take it off and I wait for the patient to respond. And if they don't respond, I reapply it until they do feel it. So why don't we just bring up our our first question to keep you all engaged, if we can, Chris. And we're going to do this here. Clinical examination, which step should you do first? We'll give you a few seconds to answer this. Visual examination for swelling and asymmetry, clinical tests such as radiographic examination. Well, we're getting lots of people here. 3% so far say clinical tests such as radiographic examination. And those that were really listening said visual examination for swelling and asymmetry. And of course, that's the correct answer. So if we can get that off the screen, I can't control it with me, with me here. So maybe Chris, Jen, you can get rid of that so we can move on. Okay, well, that's right in the middle of my screen. I don't know if it's in the middle of your screen.
Oh, shoot. Yeah, you might have to, everyone might have to click it off.
Okay, so I may have to stop sharing. I may have to stop sharing to do that. So let me, oh, here I can do that now. Ah, there we go. Perfect. All right, so we're back in action again. So hot pulp test tip, really, really good. Put a little bit of Vaseline, a little bit of lubricant on the tooth, and place it on the tooth for a count of 1, 1,000, 2, 1,000, 3, 1,000. Take it off and wait. Always start with the normal tooth. If you don't have a response, then add an extra second or two. Electric pulp test, I use it actually in every case, not for diagnostic reasons, but the reason I use it, probably the greatest use of my electric pulp test, is to test for the profoundness of the anesthesia, especially with those hot teeth, you know, those irreversible pulpitis, lower second molars, with or without apical periodontitis. You give a block, you give a Gaugates, pain goes away, you get lip and chin signs, yet, you know, you go in there with your drill and they feel it. So before I do that, I may use a little endo ice, or I may use an ice pencil first. If they don't feel that, then I'll use my electric pulp test tip. So if I hit all 4 cusp tips and they don't feel it with my EPT, I know I'm ready to rock and roll and make a painless access into even the most inflamed tooth. And it's important, you can't use it with a gloved hand like I'm demonstrating here, because you need to complete the current. You need to, if you're going to use this, what I do is I'll use it with a gloved hand, and I will have my patient actually hold the bar, the metal bar, and as we approach the tooth with them, when they feel it, they will move their hand very, very quickly, believe me. So if they don't respond to cold, I'll go to my electric pulp test. There are some false positives and false negatives. It can be a little unreliable, but I do like to use it if I don't get a response to cold. For instance, if a tooth has heavy calcification, or there's a crown on it, or the gums or the pulp is receded, sometimes you may not get a response to cold even with a vital pulp. So you may want to use your electric pulp tester in those situations. It's a great for establishing a baseline following trauma, and like I said, I always use it to test for profoundness of my local anesthesia. So that's the pulp sensitivity test. Now we're going to look at PDL tests, attaching the apparatus that the ligament joins into the bone. Now, I don't start taking the back of a mirror handle as a jackhammer and start hammering the teeth. What I'll do first is take a gloved finger and very gently push on all the teeth to see if there's any inflammation of the periodontal ligament, because that's basically what you're trying to find. You start with the normal tooth. Once again, it's the start with the normal tooth theme. And if you don't get a response, a positive response, a painful response or uncomfortable discomfort with the gloved finger, then you'll take the back of a mirror handle and very gently on a normal tooth first tap along the long axis of that tooth until you get your response. Apical palpation will often tell us whether or not there's a apical fenestration over a tooth or inflammation. Very reliable for maxillary centrals, maxillary canines, buccal roots of upper premolars, and most likely mesobuccal roots of maxillary first molars. A little less reliable with lower teeth, just because of the anatomy. But I don't use my gloved finger. What I'll do in order to make sure I'm surgically precise over a particular root is, you know, sometimes, especially in smaller individuals, my finger may actually go over the apices of 2 teeth, my glove finger. So what I'll do is I'll use a Q-tip, and I'll use the cotton end of the Q-tip, and this way I can be very precise but where I'm going to palpate. All right, just a little tidbit of information. Okay, that's what I like to do. So mobility, patients often come in and say, yeah, my tooth is really, really loose. And I'll often say, well, I'll take a look at it and it doesn't look loose at all, but they have that perception that it is loose. And to them it is, because we have, as patients, we're very discerning, and it may feel like it's wiggling in the breeze, and we go in there, there may be a little bit of a subtle motion. And of course, when you have a periodontal ligament that's inflamed, you'll often get this. So mobility, take the back of 2 mirror handles and go and test to see if it's mobile. And again, it's very subtle. It's very sublime. We often can't see it, to the naked eye. Now, periodontal probing should be part of every endodontic exam. Really, really important. Wide pocketing, often perio, long, thin pocket, endo in origin, and it may either be from a draining perio pocket coming from an endo lesion, or it could be adjacent to a vertical root fracture. It's hard to tell. And even with cone beams, as you'll soon see, it's very difficult to tell whether it's a vertical root fracture pocket or whether it's just a draining lesion, and we get fooled often. Sometimes you just can't tell, and the only way you can tell if it's a root fracture is if you actually remove the tooth and inspect it visually. And even then, it's hard. You have to wait sometimes for the tooth to dry before the fragments separate, because most fractures of roots are what we call non-displaced, and very difficult to see on an x-ray and very difficult to see on a cone beam unless you go right through the plane and the crack is quite wide. And by then it's sort of game over for the tooth. So we do get a very thin probe, and we probe along the gum, very, very gentle. Want to make sure that we do, it's almost like a 360-degree probing, because some of these pockets are very, very subtle. Now, if a patient has a sinus, some patients say, some people talk about a fistula. We always do a sinugram, and sometimes it's obvious where that lesion is draining from, and sometimes it's not so obvious. I mean, here you would think that the infection was coming somewhere between those 2 maxillary premolars, and interesting enough, the root canals have been done. This is where you would expect it to come, and then when we traced it, it traces all the way back to that upper first molar, and that was the one that needed the root canal treatment. So expect the unexpected, always trace it. This one's emanating, coming out of the tissue just distal to that upper second molar. The upper second molar responded normal to cold, but the upper first molar didn't respond at all to the cold. And not only that, but it didn't respond to the electric pulp tester. So very, very important. So let's go to the next question before we move on. Oh, let me just show you. I know you're all sitting at the edge of your seat. It's actually coming from the first molar. So when gathering subjective information from a patient, which items apply? What is the chief complaint? What is the source of the pain? Did you have a recent restoration? And of course, you're all getting this right. Good for you, everyone. Again, subjective information, right? That's important. All right, the correct answer is all of the above. So I'm going to, awesome, that's it. So that's where it came from, and then we had to do the root canal on that particular tooth. And the diagnosis was made clear. Now, this is an interesting topic, cracked tooth syndrome. I actually call it cracked tooth spectrum, because there's a spectrum of symptoms that the patient can present with, and a spectrum of treatment that we, met out to that patient, depending on what the symptom is and depending on the type of crack that it is. It can be anywhere from, taking off a cusp that may be cracked to complete split down the center where the tooth has to be removed, and everything in between. So the bite test is an important test. Now, I like the bite test. I use two modalities for this. I use a Q-tip, because a lot of times patients say, it's when I'm chewing gum it hurts, or when I'm, chewing a steak. But when I eat something hard, it really doesn't hurt. Or on the opposite, they may say it only hurts when I have a nut, right? And, of course, we try to tell our patients to stay away from hard nuts, unpopped popcorn kernels, chewing ice, hard candies. Those candy hearts are notorious for cracking teeth. And we'll get to that in a few minutes. So I'll use a Q-tip because it's got some give to it. So I'll have them bite down on the Q-tip, sustain the bite, and then release. And when they release, quite often that's when they get the pain because the crack expands. And then when they let go, that crack slams shut microscopically, and they get that sort of second wave of pain where they see, lightning rods in their mouth. If I don't get a response to that, then I'll use my tooth sleuth. The blue tooth, there's a white one, there's a blue one. The blue one is sort of has two sides to it, two ends. One is a little concavity you can put on a cusp, and the other end has a little wedge you can put in the central groove. So if they don't get a response to the Q-tip, I'll use my tooth sleuth, specifically the wedge I'll put in there right in the central groove. And quite often you get that. Those are the patients that say, when I eat a small seed, it just gets in that right spot and I see stars. So when they bite down, it expands the crack, and then we let go, that crack slams shut, and that's when the patient gets that searing pain. And you can use transillumination as well. If you use transillumination, cracks do not allow light to penetrate past it. So if you put the light on there, and I mean, you can use your curing light too, as long as you're wearing, protective glasses, you'll see that the light stops at the crack. So it's one way of diagnosing it. So let's take a deep dive into cracked tooth syndrome. I mean, we've known about it for decades, and the cracks that we often see are mesiodistally, as opposed to vertical root fractures, which are often buccolingually and start from the apex up. These usually start from the crown down and end up with a split tooth. And you like to use the analogy of a crack in a windshield of a car. Crack in a windshield of a car, just like a tooth starts off with a hard impact, maybe a stone in a windshield of a car with a tooth, maybe that unpopped popcorn kernel, ice cube, hard candy, hard nut, and then it takes less of an impact or force to propagate that crack. Your kids have always done it. You get that crack in a windshield, and no matter what you say, don't tap on that crack, right? Or a mirror or what have you, and then boop, 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 it spreads down. It's very similar to a tooth. So very hard sometimes to diagnose this, and sometimes even harder to recommend what kind of treatment to recommend. So if we take a look here, we have our Iowa staging index, and I'm just going to exit for this for a second, and I'm going to minimize this because it's interfering with my slides. There we go. So the Iowa staging index, you look first, is there a pocket? And if there's a pocket greater than 5 millimeters, we know the prognosis of that tooth is not very good. If there's no pocket, we look at the distal marginal ridge, we see if there's a crack in it. If there's no crack, but you're still getting those symptoms of cracked tooth syndrome and you can't visualize one, that has the highest success rate. Now, if you do see a crack and we make a diagnosis like chronic apical periodontitis, symptomatic apical periodontitis, or acute apical abscess, then, if you don't have a necrotic pulp, then the prognosis is not as good as the first stage, but, not as bad as if they do have that necrotic diagnosis. And the success rate of cracked teeth syndrome decreases as we have more things sort of piled on top of it. So these are the things you want to look at. Number one, is there a pocket? How deep is that pocket? Number two, is there a distal marginal ridge? And what's the pulpal status? Those are the three most important things when we decide and we talk to the patient about the prognosis of a particular tooth that has a crack. So we need to make a decision, and I'm going to sort of show you the decision tree, and you can all take pictures of it if you want. Happy to send it to you if you want. You have my email address, and I'm happy to send you anything from this presentation. And basically, we want to look at the prognosis of these teeth. And this particular study, they found that the determining factor deciding on treatment of these teeth hinges obviously on the extent of the crack, right? The extent of the crack. So those that had coronal cracks and didn't extend into the root obviously had a higher prognosis, and those that extended into the root proper had less of a prognosis. But we also have to pile that on with, is there a pocket or not? Because I've treated many teeth where the cracks extended to the orifice and into the orifice, and I've done, and I'll show you what I do. I do intra-orifice bonding, but there's been no pocket, and these teeth have lasted years and years and years, and certainly there's a lot still in patients' mouths. So just because you have a tooth that has a crack in it doesn't mean that it's destined to extract. But that being said, we need to manage our patients' expectations, and I always tell my patients, no matter how innocent the crack is, that cracked teeth are probably the most unpredictable, grayest area in dentistry, because we're never sure how far that crack's extended or how far that crack's going to extend during the lifetime of a tooth. And you may have that tooth forever and ever, or you may, bite in something hard and continue on with your bad habits of eating unpopped popcorn kernels in movie theaters. And just like that crack in a windshield of a car, it may continue to extend. So, and you may end up losing it. So what do we do here? So this is the decision tree. First thing we do, cracked tooth, distal marginal ridge is cracked. I'll give you a scenario. No pocketing. Feel sensitive when they bite on it. You put cold on it. Yes, it's sensitive, more sensitive than the surrounding teeth, but it goes away right away. So what we do is you can internally split that crack line with composite resin, and then put an ortho band over top of it. Bring the patient back, and if they are asymptomatic, then you can put a temporary crown on, leave it for a month, and then you can go to a permanent crown. If, however, that doesn't help, the ortho band, the temporary crown, and they continue to be symptomatic, then you may need to do endo treatment. So here's the decision tree right here. This is a great picture. Cracked tooth with reversible pulpitis. You band it. You put an ortho band on, and you bring them back in 2 weeks. And if they're fine, then, put a temporary crown on there. Leave it for a month. If they're fine, they're asymptomatic now, they don't have that bite sensitivity, the pulp remains vital, then go ahead and do a permanent crown. If, however, they remain symptomatic after the temporary crown, then root canal treatment followed by the crown. And of course, if they remain symptomatic, we've warned the patient, we've managed your expectations. If they can't tolerate it, then, extraction is an option. But I will tell my patients that cracked teeth, because it's such a gray area in dentistry, they may always have an awareness of the tooth. They may not have the same pain, and they may be able to chew on it. The more discerning the patient is, the more awareness they may have. I'll tell them they may have an awareness always on that tooth. It may always feel different. If you can live with that, then I recommend that you live with it. If you can't, then of course, extraction may be a viable option for them. So looking at these studies again, 97% of the teeth were followed up for 4 years, not a long time, but the pulpal rate was 72% after banding and 91% after final crown cementation. And in this study, no teeth were extracted. The only, interesting enough, significant predictive factor for pulp survival was pain on percussion. Teeth with pain on percussion at the first visit had a pulp survival rate of 46%. And during the follow-up period, in comparison, their counterparts without pain had 94% pulp survival rate. So here's a college chum of mine. He came in, I don't think he'd been to the dentist at all, ever. And you can see there's some calculus in between his teeth. And one of the lucky ones, virgin teeth, never a problem. But he had this anomalous enamel projection on the tooth. And you saw this earlier in the presentation. You can see the crack going from the top of your screen right into just adjacent to that anomalous projection. And he loved to eat unpopped popcorn kernels. And then what happened was it was sort of the straw that broke the camel's back. He bit into that just before the trailer was ending, just before the main event. He was finished his bag of popcorn, pulls out the popcorn kernels and crunches, and he saw stars. And we looked into that tooth, but he felt the cold and it didn't go away. So we had an irreversible pulpitis, cracked tooth syndrome. Wasn't sensitive to tapping, but when he bit down, boy, did he see stars. No pocket adjacent to that crack. So we were fortunate. But you can see also that crack's not new. It's heavily stained. We made a sort of a preliminary outline form of what our access was going to be. And you can see this hemorrhagic pulp. Now, at the time, this gentleman was probably 50 years old. And, in a 50-year-old pulp, you tend to see more of that stringy pulp, that white pulp that you go in. That's a normal pulp. You don't see a vascular pulp that's beating to the beat of his heart. Boom, 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 boom. You see vascular pulps in little kids, but you don't see this type of vascularity in an adult unless it's irreversibly inflamed. So you can see the crack extends through the pulp chamber, but not past the pulp chamber floor. What you see there is embryological fusion lines, but we were fortunate. And then I told John, I said, John, you may be one of the lucky ones. I can't guarantee it. I never guarantee anything. But if you could give me, prognosis, I would say this tooth has a great prognosis. So we did the endo, we did the restoration. John came back I think 10 years later, and I looked expecting to see that, that second molar not there anymore and replaced by an implant. And lo and behold, he still had that tooth. So it hurts me and it burns me when I hear patients coming to see me where my dentist saw a crack, he wants to pull it out. So you can't, fit every cracked tooth in the same hole. Every tooth is different depending on these different factors. Is there a pocket? Is there distal marginal ridge? What's the pulpal status? Is it necrotic? Is it vital? It's a vital tooth. It's probably better prognosis than if it's a non-vital tooth because it's probably more of a long-standing crack. Although I will show you a case where I think it is a long, thin crack with a vital pulp. But it's interesting. In this tooth here, that lower molar, boom, split. That was a candy heart. That was a candy heart episode. Patient got some candy hearts on Valentine's Day. Loved to turn them on the side and crunched on them. Don't know why he would do that. You may as well take a chisel and a hammer and start hammering away on your teeth because that tooth obviously had to see the extraction. Another virgin tooth, palatal cusp, plunger cusp, boom. Patient just bit on that tooth and you see a 10 millimeter pocket. This tooth has to see the sun. So this is something I do routinely. Before, when I first started practice, I used to see cracked teeth maybe once a week. And then before COVID, before the pandemic started, I probably saw it about 2 times a day. And now since the pandemic, for some reason, I'm seeing like 3-4 times a day, cracked teeth. And, I had a day of consults the other day where I told every patient to take their tooth out. It was just not savable. And, then I'll have days where every patient that I see is a root canal, and probably half of those are cracked teeth. And we give them the option, we tell them the prognosis, we tell them the possibilities, we manage their expectations. So when we look at these teeth and we look at the success rate of them, it's important that we look at the depth of the crack. Is it coronal? Is it radicular? Is it go to the pulp chamber and doesn't go past the pulp chamber floor? Does it go in the actual canoe, into the canal? So we want to reduce the occlusion. It's really, really important. And we want to place a crown on that, well, at least full coverage as soon as possible. Okay, that's really, really important. So take a look. See the blue arrow there? That's the apical extent of the crack there. And so what we do is we remove gutta percha south of that crack, apical to the crack. We etch, we bond, and we flow in some flowable composite to try to bond that crack on the inside. These types of teeth, I would not have a pocket. If it had a pocket in it, like greater than 5 millimeters, I would tell the patient the prognosis wasn't good. And again, give them their choice. But that being said, I've retained a lot of teeth with 5-6 millimeter pockets that have remained 5-6 millimeter pockets for decades. So just put that in your hat for a few minutes. Here's a patient that came in. These are one of those patients that, I got pain. It starts up here, starts in the top of my head. It goes to the bottom of my toes. And I can't localize it, but I know I can't sleep. And it's really bothering me. And I tested all the teeth and they all responded within normal limits. This patient happened to be a bruxer. So we sent her to the facial pain specialist, not that far away from us. And he couldn't make heads or tails of it. And I said to my patient, you know what? Neither of us can figure it out. Let's bring you back in a week and I'll retest it. And I give my patients my business card with my cell number, my email address. And I said, text me any time of the day or night, except between the hours of 11 o'clock at night and, 6 in the morning, of course. And I will be there for you. Because what happens often, then we reschedule them for a week later. And I said, if anything changes, no matter how trivial you think it is, I want you to let me know. Because sometimes what happens is over that period of time, the pulp sometimes can go necrotic. All of a sudden the pain stops until such a time that it becomes acutely infected. But if we bring the patient back a week later and the patient says, yeah, ever since I saw you, the pain stopped, I'll retest my teeth. And lo and behold, when I retested these teeth, the lower second molar responded non-vital and now is a little sensitive to percussion. So, it had that crack in it, that dastardly crack. Crazy how these cracks occur. We did the endo, did the restoration right away. And, 6 years later, the patient still has her tooth. No pocketing, but that crack on the inside of the tooth, that distal crack extending to, but not past the pulp chamber floor, maybe even going in a little bit past the pulp chamber floor into the orifice of the canal. So sometimes the diagnosis and the treatment are linked together. That typical J-shaped lesion, right? It's going to be my nemesis because we're always taught, if it's a J-shaped lesion, it's got to be a root fracture. And in this particular case, first molar, lower first molar, just a small buccal amalgam, long, thin buccal furcation pocket, sinus tract, which all both led to the mesial of the distal root. And you can see the whole furcation bone was blown out. So we got to start thinking, like, why did this pulp, and I'll tell you, why did the pulp go necrotic? Well, probably wasn't due to the amalgam, most likely due to a crack. But then we have to start to think, is the crack, extending along the line of the pocket where the prognosis is not going to be good? Or is the crack somewhere else in the tooth and it was deep enough, the crack, to cause the pulp to become necrotic, and now all we're seeing is a draining lesion? So this is where that J-shaped lesions, theory sort of comes into play. Like, is it a draining infection or is it due to a root fracture? So yes, there was a crack. You can see the distal crack in the sort of upper left of the screen, extended to, but not past the pulp chamber floor. It caused the pulp to go necrotic. And when it went necrotic, the bacterial contents went down to the apex and started to destroy the bone, and the infection drained through the buccal furcation. And that's basically what happened. So we did the endo, and we can see this 3 months later, how things have healed beautifully, the bone, and even better. Look at that, complete regeneration of the bone. And you can see a little scarring of the fistula. Often you'll see that little scarring of it, and no pocket, of course. So these are the types of cases that, I love when patients come in with sinus tracts or pockets that are draining from infection, because I know if the endo is going to work, that pocket or fistula, sinus tract will resolve pretty quickly, sometimes within a day, sometimes within a couple of weeks or more. So here's a question. Maybe we should go to our next question before we move on, if we can do that. All right. So objective information is gained by 1, interviewing the patient, 2, planning for treatment, 3, conducting clinical tests, or 4, assessing the information. Objective information. All right, give you another second or two. See someone popping up, interviewing, they're not quite sure. Not sure if you can change your answer or whether you're locked into that answer. There you go. Objective information. Remember, objective. These are clinical tests, okay? So that's important to know. All right. Let me get rid of that and we'll move on. Okay, so let's go back to that. 30-year-old male patient referred for assessment of a deep pocket at the distal buccal of his mandibular left first molar. And the patient just complaining, a little swelling on my gum for the past 3 months. And we look at that first molar, and it's got a beautifully fit crown on the tooth. And wow, I can see root canals. I haven't seen a root canal in probably decades, because cases that are referred to me, they're either previously treated or solid blocks of dentin. But wow, what I would give to actually drop into a pulp chamber one day. So this particular tooth tested non-vital and had a very, very deep pocket, an 8mm distal buccal periodontal pocket. So naturally, I said to the patient, "Oh, you probably got a crack, probably, we may have to take the tooth out. We can do one of two things. You can take it out and get an implant right away, or if you want, I can make a preliminary access and see if there's a crack. And if there isn't, I'll keep going." And I went in, and this is the pocket. And you can see the bone loss there as well. And you can see the bone loss here on the top right-hand side, distal bone loss. And we did the endo, and lo and behold, there was a huge honking lateral canal. Crazy. I almost perforated in that pulp chamber. I got so excited. It was like a sliver of a pulp chamber. I just almost perforated into the furcation, but I did not, thank goodness. And large lateral canal. And you can only really get this when you activate your irrigant. You have to activate your irrigant with, probably the least expensive way to do that is to get yourself an endo activator or an ultrasonic endo activator Dentsply Sirota makes, and it's a fantastic. They have nylon tips. They don't break in the canal. The new one cycles at 18,000 cycles per minute. It really causes acoustic streaming, cavitation, removes the tissue, cleans it out real nice, and then using a warm vertical technique. Warm vertical gutta percha continuous wave with one of those systems, down pack system that you may have, whether it's a touch and heat or a system B or a gutta smart or an elements free by the different companies, just in the interest of fair balance, of course, going through the mass of gutta percha, creating those hydraulics and getting that three-dimensional impression of that root canal system. And lo and behold, patient came back 1 week later, pocket was gone. Intraoral imaging is very, very important. You know, everybody gets a new x-ray when they come into my office. Now, especially if the patient says, yeah, my dentist went in and tried to do the root canal, and then they send the pre-op x-ray before the dentist made access. Take another film. Take two angles. You want to three-dimensionalize that two-dimensional image wherever you can, because you want to, figure out, the anatomy if you don't have a cone beam. And that's really, really important. Then, of course, extraoral imaging. We have a cone beam, and I love my cone beam. A day doesn't go by where I don't use my cone beam. I think that it's important that we visualize the tooth. Let me see if I can bring this up here. Here we go. Let me manipulate this. And probably my biggest use of my cone beam is the, let me see if I can get that going. I don't know why this isn't working. Let me see if I can do it again. Come on. Come on. Okay. It's not working. But three-dimensionalize that tooth, looking at it not only from 3 dimensions and knowing the exact anatomy of it, knowing if there's an MB2 canal and whether you should be looking at it or looking for it or not, and also, knowing the relationship between normal anatomical structures like the where that mandibular nerve is, right? Because we want to know where that mandibular nerve is, so obviously we can stay away from it. So here's a case that was sent to me from one of the Eastern Bloc countries, and I was sent to retreat the root canal. And we went in there, and you can see here, take a look at the, let's see if we can bring this up. Yeah, this movie's running. Take a look at the top left there. Look at the mesiobuccal and distal buccal roots. The gutta percha is not centered in the middle of those roots. They're eccentrically placed, laterally positioned. And if there was one canal, it would be in the center of the root, like that palatal root. When it's off laterally positioned, then it often indicates that there may be a DB2 and an MB2. And certainly that's what we found. Wow, we're just looking for the MB2. Now Glassman's telling me look for the DB2. Well, what I am telling you is expect the unexpected. If there's one canal, look for two. If there's two, look for three. If you have access to a cone beam, I take a cone beam virtually on every single posterior tooth that I treat. I don't want to guess what the anatomy is. The buck stops with me. I don't want to retreat my own cases, because if I bring a case back that hasn't worked, I'm going to take a cone beam on it anyways. So pretty typically take a cone beam now. I want to outline that anatomy. I want a blueprint for success. Intraoral imaging, great for patient presentation, as well as obviously decreased radiation. I still know some docs, and maybe even some on this call tonight, haven't made the change to digital radiography, and they're still using dark rooms. Well, you need to get out of the dark ages and get yourself a digital platform. 95%, up to 95% less radiation. You can manipulate the images. They're small sensors, big sensors. And if you underexpose, which we often do, just to decrease the amount of radiation, you can hit one of those enhancement features and increase the contrast. Selective anesthesia. Here's an interesting case. I'm not sure why the dentist sent me the case, because of the impacted premolar. They said, oh yeah, you got pain. Maybe it's because of the impacted premolar. Not sure why they sent it to me. It's not like I'm going to do endo on that impacted premolar, but I tested all the teeth. They all responded pretty normal. Lower molar, patient had an ache on the right side of their face, and everything tested within normal limits. So I decided, they thought, well, maybe it's more in the top. Sometimes it's in the bottom. It goes up to the side of my jaw. I'm really not sure. So what I did is I dropped a little carbocaine, no epinephrine, just like an eighth of a carpule distal to the upper second molar, enough to anesthetize the second molar, but not enough to anesthetize the first molar. And I know I didn't anesthetize it because I tested it with cold, and it responded normal to the cold, and the upper second molar did not, but the patient's pain vanished. So this was great. And of course, our nemesis, the crack. These cracks, sometimes they can mimic neurological problems. Sometimes patients with neurological problems come into our office with full mouth endos, and the pain still persists. So it was a misdiagnosis. So sometimes it can be neurological. Sometimes, patients are being treated with gabapentin for a neurological problem when it could be a cracked tooth. So it sort of works both ways. This is the case I did many years ago. Did the endo, dentist wanted a post space in there with that crack, and 10 years later, the patient came back for another tooth and it still held. So interesting. Tooth has a crack. I don't really recommend a post. I just don't want to cause that crack to get any further. And this is something that I'm just including for historical purposes. I don't really do this anymore, but this was called a test cavity, where you take a quarter round burr and a high-speed handpiece without water and drill into a tooth, and if there's any nerve fibers that are vital, it's supposed to cause pain. If you want to get any secret banking information from patients, this is a great tool. I don't know if anybody of you saw Marathon Man. Is it safe? Right? I sort of take this out of my repertoire. This scares the heck out of patients. So we've done our sensitivity testing. We've done our periodicular testing. Now we're going to do we're going to make our diagnosis according to the American Association of Endodontists. We make a pulpal diagnosis and a periodicular diagnosis. Is the pulp normal? You feel the cold, it goes away right away. Comparing it to the normal teeth. I'm not comparing it to a patient who's got horrible sensitivity in all their teeth because they clench, they grind, they eat citrus fruits all day long and sweets, and they have general sensitivity. I'm talking about a normal pulp compared to the other normal pulps. Reversible pulpitis, an example is patient has a decay, you remove, and it's sensitive to cold, you remove the decay, put a filling in, restoration, and the pain goes away. Symptomatic irreversible pulpitis is it's one of the emergencies, one of the two emergencies I'm going to touch upon in a few minutes, where the patient has pain and the pulp is irreversibly inflamed, and you got to get in there and you got to remove the inflamed pulp. The next one is a little bit more difficult to understand. Asymptomatic irreversible pulpitis. How do we know it's irreversible pulpitis if it's not bothering the patient? Well, these are those patients that have that bombed out decay. And you know what I'm talking about. You see them. I saw them especially when restrictions were lifted and patients hadn't been to the dentist in a couple of years. And they came in with bombed out decay, but it wasn't hurting them. And they say, "Oh, why do I need a root canal? It doesn't hurt." And I get that all the time. Pulpal necrosis, pulp's non-vital. Previously treated, previously initiated therapy. Well, that speaks for itself. That's the pulpal diagnosis. Periodicular diagnosis, also known as an apical diagnosis. Normal apical tissues, normal to percussion, normal to biting. Symptomatic apical periodontitis, it hurts when I bite. And asymptomatic apical periodontitis, just like the asymptomatic irreversible pulpitis, patients aren't feeling any pain, yet they got these massive lesions. You take an x-ray, it's necrotic, they've got asymptomatic apical periodontitis, and they're always associating, oh, well, I heard root canal, you have to have pain, and that's just not true. Acute apical abscess, chronic apical abscess are those cases that are draining through a pocket or a fistula, sinus tract. Acute apical abscess, that's second most common endodontic emergency. And then condensing osteitis. Sometimes it can just be an incidental finding where you have increased density of bone around an apex, or it could be due to chronic inflammation of the pulp that's just ongoing for many, many years, even though the patient may be asymptomatic. Now, during COVID, after COVID, I saw a lot of dentin hypersensitivity, a lot of it. Patients were sent for root canal treatment where it was not necessary. And, causes of, dental hypersensitivity can be, depending on what your diet is, clenching, grinding, broken fillings, brushing your teeth too excessively. These are some of the reasons why. And then what happens is the enamel becomes demineralized, they increase their sensitivity. But how does this happen? Like, how does it occur? What's the mechanism of dentin hypersensitivity? We know there's dental tubules, they're fluid filled. And when that fluid goes back and forth, either due to sweets because of the osmotic differences in pressure, hot and cold, expansion, contraction of the fluid inside will stimulate the nerve fibers, the pulpal nerve fibers, and get the pain. So how do we combat that? How do we combat it? Well, we combat it by one of two ways. Either you prevent the movement by blocking those dental tubules so the fluid doesn't go in and out, or you depolarize the nerves. So what I say to my patients is, yes, you may need root canal. It's quite possible. You may need root canal, but let's try something really conservative. Because when you test the teeth, yeah, it was sensitive, but it went away within a short period of time. Yeah, it was more sensitive in the surrounding teeth, but it went away. So, and it doesn't hurt when they're standing there, only when they have, stimulus like sweets or cold or hot. So I'll give them a tube of Crest Sensitive, which has stannous fluoride in it, which will block the dental tubules, and I'll give them a sample pack of Sensodyne, which has potassium nitrate or potassium chloride. And what that does, it depolarizes the nerve. I say use one in the morning, one at night, and see if it works. Use it for a week or more. And, text me, let me know how it works. And I will tell you that when I do this, I'd say about 50% of the patients remain asymptomatic. And the other 50 don't. Some of them live with it and say, I can live with it. It's okay. I don't need root canal. Don't do root canal. And the others say, no, it's not tolerable. I can't enjoy the things I like to do, like eat and drink hot and cold things. So I want to, I want to have the root canal done. So at least we've given them that opportunity. And when the patient makes the decision to accept treatment, at least they've been given the most conservative treatment. And it looks good on you as well, rather than, well, let's go in there and do a root canal. Sure, that root canal will take care of the problem, but it may not be necessary. So block those tubules. If you have recession, that stannous fluoride can create that little smear layer over top of the exposed. You actually get these smear plugs right inside the dental tubules. Now, sometimes, there's just no reason why the patient has pain. They come in with full mouth root canals, yet they say, oh yeah, I still have, tooth pain. So, these are the things that you have to, sit back and go, what is the reason why they have pain? Maybe it's maxillary sinus, especially around this time, patients are getting colds, getting flu, their sinus get filled up with fluid and all of a sudden they get, tooth pain. Cardiac origin. I've had 2 patients over my career where patients have had what I call a long heart attack, where they were having heart problems and they had the jaw pain that went down in the arm. Fortunately, these 2 patients are fine. But it can be cardiac origin, especially when you test everything and everything tests normal. Psychogenic pain. Well, people just like to come in and talk. You know that. I mean, I've seen those patients. I'm sure you have as well. Trigeminal neuralgia, atypical facial neuralgia, very common as we get older to get these neuralgias. Shingles. I encourage everyone to get that shingles vaccine at the appropriate age, because I get patients coming with horrible pain in their face and jaw. Everything tests normal. Then 2 days later, a day later, they call me up and they go, oh yeah, I got these little skin eruptions now. Or they're having pain up here, the temporalis, and they think it's, a TMJ or temporomandibular joint disorder, what have you, whatever you want to call it, but and then 2 days later, they get the eruptions in their forehead. And then myofascial pain, because myofascial pain, I see this just like I see cracked tooth syndrome rampant since COVID. I see MSK problems all the time now, and I don't treat them, but I can screen for them. So it's important that, there are courses that you can take, and if you're interested, I can direct you to good ones. But it's important that you can at least, understand what the most common TMD diagnosis are, whether it's anterior disc displacement, myogenic pains from overuse of the muscles of mastication, cerviogenic origin, coming from the cervical vertebrae, where you get musculoskeletal pain, and of course, temporomandibular degeneration. So these are all things that, we need to screen for. Is the patient a grinder or clencher? Have them open their mouth. See what their maximum opening is from its lower incisor to upper incisor. Do they have clicking? Is the jaw, moving on one side? Does their jaw dislocate when they yawn? I had a patient yesterday that said, don't open my mouth too much because it's dislocated before. So we put a bite block in, just, not too wide, but just wide enough that I can get my fingers in there to do the root canal. And of course, my NITI files as well. Muscular fatigue, headaches. These are all things and symptoms to screen for. So we want to look, we want to observe, we want to see their opening, we want to see if it deviates when they open their jaw, what their range of motion is, palpate. You can do some testing depending on your level of training, and or refer to someone who does this all day long. We have a great clinic that we refer to. It's not a dental clinic. It's a chiropractor physiotherapy clinic, the Jaw and Facial Pain Center at 1 St. Clair Avenue East in Toronto. I don't know whoever's from Toronto. It's Dr. Sid Lisser, Dr. Sam Yagaber, Dr. Chris Oswald, great team. They probably see more MSK patients, then you can shake a stick at, and they're excellent diagnosticians. And if they feel that it's out of their scope, which is really great for a practitioner, they'll either refer it back and say, yeah, I do think it's a tooth problem, or have a team of other specialists that they can rely on, whether it's referral to hospital to see a neurologist or ENT or what have you. They're really good for this. So we send lots of patients there where we just can't figure it out. If it's a tooth problem or not. So we want to look at all these different things. We want to screen for range of motion. We want to see how many knuckles you can get in there. 35 millimeters, that's considered full opening. Just look at all these different things at rest, at passively, resisted, and palpation of the jaw. Again, these are all things that you can learn. If you're interested in learning more about this or taking a program, please get in touch with me. I will arrange it with their office. We can do sort of an evening seminar where you go to their office, they'll serve you a sushi dinner, and then talk to you about how to screen properly for MSK. Because it's important to screen properly, because it may not be a tooth problem that you're looking at. It may be, an MSK problem or a neurological problem as well. So it's really, really important. So once we've done all this, we plan for treatment. But occasionally I get stumped, and I, no matter how frustrated I am or the patient is, I still will not treat what I cannot diagnose. So give your patient your business card, give them your contact if you feel comfortable doing that, or have them call the office if anything changes, but reschedule them. Having that appointment scheduled gives a patient really good peace of mind. And if anything changes in between, have them, again, peace of mind that you're always available, or someone in your office is available to see them at a moment's notice if you take emergencies on that basis. But before we even consider endo, we want to make sure that the tooth can be saved. Okay, we've decided, yes, it's an endodontically treated tooth, but, is there sufficient crown root ratio? Can you create a ferrule? What's the thickness of dentin that could be acceptable? It's got to be at least greater than 1 millimeter, or else that tooth is destined to crack. I'll have days. I had a day last week where, yeah, I could do the root canal, but the tooth wasn't restorable, and I recommended extraction. I have some dentists which are really amazing, and will do crown lengthening and can restore a pulp stump. But again, we got to be practical, and we got to take what's in the best interest of the patient. So let's look at some cases. Okay, let's look at some cases. 29-year-old female referred for endo treatment for mandibular teeth. You'll love this case. The dentist actually referred this patient for root canal treatment on all 4 lower anteriors. But guess what? Those lower anteriors all responded within normal limits. So what do you think? I'm reading your mind. I think that you would not do endo on these teeth, hopefully, because what this was periapical segmental dysplasia. And what do? We do nothing. We watch it. Interesting. Take radiographs of the posterior teeth of the same individual. You'll see, very similar lesions. Radiopaque, radiolucent, mixed sort of lesions. It's a benign fibroosseous lesion. And what would be really confusing if now, let's say that lower first molar on the left went non-vital, and there was a periapical lesion superimposed over fibrous dysplasia, periapical segmental dysplasia. So you look for changes. You look for symptoms. Sometimes it's very difficult to tell if it's actually healed or not. So let's go to our next question before we go to the next case. All right, the most important thing a practitioner should do first is perform radiography, listen to the patient, perform cold testing, perform hot testing. Oh, I love this, because what this means is that you were listening to me. So that's right. You want to listen to the patient. Very, very important. Okay. So let's get rid of that. Let me see if I can exit that. And all right, here we go. Another patient, same problem, different patient. All right, here's a 70-year-old male referred for endo treatment on a mandibular left canine. The dentist found the infection on the x-ray. All right, and wanted me to do root canal on this lower canine. Says, oh, it's infected. Didn't see any reason why it should be infected, but this is an older gentleman, and you'll wait till you see this anatomy. Take a look at that anatomy. It's like one of those houses built on stilts. This tooth was, look at that thin mandible. I mean, I'm afraid if this patient just rests their finger on the mandible, it'll crack. No pathology. Patient's blood work came back perfect. But what's happening is the radiographs just penetrate that bone so readily that it appears more radiolucent than the surrounding teeth. And the dentist thought, look at that, there's that stilt right there. Dentist thought that it needed a root canal. What it needs is probably a plate to reinforce that. So interesting case. Interesting case. So here's a case for the books right here. This patient came to me after having been to their dentist, and the dentist took a scalpel trying to get some drainage there, and then got fed up because he couldn't get any pus out, sent it to me to do root canal on that lower canine, and that canine tested vital, and it was interesting. I didn't like the way that lesion looked, so I sent that patient to the pathologist, who did a biopsy and found it was non-Hodgkin's lymphoma. Interesting part of this case is that it was the primary site. Patient had PET scans for years, and this was already decades ago. And I know the patient's still around, and they didn't find any other, lymphoma in the rest of their body. Kind of unusual, but obviously didn't need root canal in order to solve that problem. 66-year-old male patient was referred for assessment of pain in the lower right first molar. Root canal was done 20 years ago. And interesting enough, the dentist didn't take a pre-op x-ray before they cemented the crown. And all of a sudden, even though that lesion isn't new, the patient had, pain and swelling. And of course, they took an x-ray and they saw a lesion. So, the question is, what do we do? Do we extract the tooth? Do we do root end surgery? I suggest that we retreat it, which is what I did. And I always tell patients, again, this is about managing expectations. I always tell patients that it's possible the crown could break, the crown could loosen, you may need a new crown, porcelain could fracture. Because usually when I tell patients that, it never happens. It's when I forget to tell the patient of the possible risks, which is far and few between. But, Murphy's Law, you don't tell the patient all of a sudden the porcelain cracks and now you own the crown. So we did the endo. The patient was really disenfranchised with their dentist and decided to go to a different dentist. And the dentist did a full series of x-rays. And keep your mind ingrained on that post-op right there and take a look at it 6 months later. I'll go back, and now we see healing, but the dentist took an x-ray, and at that point in time, there was a radiolucent lesion, said to the patient, oh, you have infection there. Well, that patient came to me with all guns blazing. I thought you removed the infection. I paid good money to have the root canal done, and then the crown, then you did another root canal and I have infection. And I went back and I said, well, look at this. And look at that. I said, let's wait and watch. Calm the patient down. They're asymptomatic. Got them back in a year. Things are still there. And then boom, 2 years later, complete regeneration. It takes time. The body is in a state of dynamic healing. Interestingly enough, I had a patient a couple of weeks ago where I went over the diagnosis. There's an infection around the end of the root. And the way we deal with this infection is we remove the bacteria from within the root in order to give the body a chance to heal. So I did the root canal. I sat the patient up and took a final x-ray, and they go, the infection is still there. And I go, well, yeah, it takes time for the bone to heal. So point is, manage expectations, make sure the patient understands that it takes time for things to heal. 46-year-old male patient was referred for assessment of pain in the lower left first molar. Root canal treatment was started in the hometown 3 days ago, and the pain intensified. Now, this is the kicker. Same symptoms as before, but worse now. The main symptoms were cold sensitivity. So the dentist went into that lower first molar, and what you see is a pulpectomy and then calcium hydroxide. Patient came to me with cold sensitivity. Now, if that was the tooth that had the cold sensitivity, patient wouldn't have any cold sensitivity anymore. Once you do a pulpectomy, very unusual to experience cold sensitivity on a tooth. So we went back a little further and we saw it was that second molar that was the culprit. Interesting case in that not only was it sensitive to percussion and biting and cold, but it had a 10-millimeter distal pocket and a crack. So I surmised that the cracks probably knew there was enough breakdown of the PDL adjacent to it, but the pulp hadn't gone non-vital yet, which is very, very unusual. Usually when you have a crack like this with a deep pocket, then usually it's necrotic, but this one wasn't. So I took out the tooth, hadn't taken out a tooth in years, and you can see that crack. And then the patient came back, a few days later, and I finished the root canal on the lower first molar. And the question was like, did I really need that root canal to be done? And obviously my answer was I started to learn how to tap dance at that particular time. And I said, well, eventually you probably would have needed it, but make a diagnosis. Okay. If you can't make a diagnosis, then don't treat. All right, let's take a look. This is part of my Endodontic Solutions program, and I'll touch on what's available to you for continuing education as we finish up today. But I do want to talk about emergency treatment. When everybody was closed down for those 3-4 months in 2020, we were open. We were a triage unit. We were hazmat suited up. We were seeing patient after patient. I hadn't done a class 2 restoration in years, because most of my cases I would send back, and I'd say probably 95% of the time, to my dentist to do the restoration. So I took one of those online remote courses that Clinical Research Dental offered with Bob Margis, and they sent me a kit, and I went online. I learned how to do a class 2 composite. You're probably all laughing, but I could do a root canal in the time that you can extract a tooth, but it would take me about 7 hours to do a crown prep, because I don't do it. So I learned how to do a class 2 restoration. Now I probably restore about 25% of my teeth. And, incidentally, the best time to restore an endodontically treated tooth is at the time of obturation. Leaving it and waiting, I don't understand what you're doing, because you're just waiting for the temporary filling to break, to leak, and to become recontaminated. So if you build in a little extra time, not only are you doing the patient a favor, you're maximizing the prognosis of the tooth, but you're also increasing your productivity, because you don't have to bring that patient back for a second visit. Because you got the dam on, do the restoration, it'll take you another 5-10 minutes, as opposed to dismissing them, bringing them back, anesthetizing them again. You're going to book an hour for that. Maybe a little bit less. I don't know how fast you do restorations, but that's my experience. So that being said, during COVID, we saw emergency treatment left, right, and center. The objective of emergency is you bring the patient in, you get them out of pain and or swelling. So we'll talk about the two most common emergencies is when the pulp is vital and they have irreversible pulpitis with or without apical periodontitis, or when they come in with a necrotic pulp with an acute apical abscess with or without swelling, and they're handled completely differently. So patient comes in, you make obviously a diagnosis, you go through your soap, and you unravel the mystery. You go through your test, you figure out what the problem is. So you figured it out that it's irreversible pulpitis. Okay, irreversible pulpitis. So what do? Well, you remove the pulp. Now, you can do a pulpotomy or you can do a pulpectomy. Pulpotomy you would only do if there's no radicular involvement. In other words, if there's irreversible pulpitis without apical periodontitis. You go in with a sharp, fresh round diamond, make access. You want to make sure the radicular pulp isn't bleeding. And if it's bleeding a little bit, you can take a cotton pellet soaked in full-strength sodium hypochlorite, place it over top, and get the bleeding to stop. Just put some pressure on there, and then cover it maybe with a layer of calcium hydroxide, temporary filling material, and bring the patient back when you have time to complete the root canal. But if you find that the patient has irreversible pulpitis with apical periodontitis, you go in, you do a pulpotomy, and the radicular pulp will not stop bleeding, then you need to go in and do a pulpectomy. Okay, you have to have the absence of apical periodontitis to do a proper pulpotomy. Now, what I was seeing was antibiotics were being given left, right, and center for irreversible pulpitis. There's no infection, right? Antibiotics are useless. The only way antibiotics are going to be working in this situation is as a placebo. Mrs. Smith, here's a prescription. It's going to get rid of all your pain. It's the most amazing pill. You can take one pill and everything's going to be good. And of course, she takes the pill and it looks good. You can give them a sugar pill. So no, I can give you a million studies that say no, antibiotics are not recommended for irreversible pulpitis. It needs to be managed with root canal treatment, or you take out the tooth, either one. So what do? We want to do it cheap and cheerful. You anesthetize the patient, you access the canals, you do a cursory shaping. What does that mean? It means until you get the red out. Remember the commercials with Visine? It gets the red out. Cursory shaping, wait till the bleeding stops. Irrigate, calcium hydroxide, and then temporary restoration. And Bob's your uncle. Bring the patient back when you have time to do proper treatment. So that's irreversible pulpitis. Irreversible pulpitis with or without apical periodontitis. If it doesn't have apical periodontitis, you can do pulpotomy. If it does, you have to do minimally a pulpectomy. Now, during COVID, because this is all I do all day long, I would do a complete clean shape pack and I would restore the tooth and send the patient on the way. Because one of the objectives was not to have the patient have to come back and forth, right? Because that just exposed them more. So you're sort of caught between a rock and a hard place, because sometimes you do the pulpectomy and they flare up and you got to bring the patient back because some pulpal remnants were left behind. So we just did a full, what we call CSP, clean shape and pack, and restore. Next classification of categories of emergencies is necrotic pulp with acute apical abscess. Number one, this is subpart 1. Subpart A is with pain and swelling. So what do? Get drainage. Reduce the pressure. I like to do it right through the gum or the tissue, if I can, pardon me. Just get in there, even without anesthesia. Boom, have the patient take a deep breath in, and as you're taking the deep breath in, you give a stab, you come out, and you just milk that baby. And you get that pus coming out, and often you'll hear from the patient a big, ah, right, as they relieve the pressure. Now, if you don't get drainage through the tissue, then you have to get drainage through the tooth. And we open up into those teeth, and you can see the viscous pus that comes out of these teeth. Now, a lot of times what happens is the pressure of drainage will equilibrate with the atmospheric pressure, and you'll stop getting the drainage. So, but you want it to keep draining. Sometimes it's really thick and viscous. So I'll go in with, I use something called the Endovac. It's a system of apical negative pressure. There's a macro cannula that's attached to a little wand, which is attached to clear plastic tubing to our high volume suction. Ultradent has, and other ones have these little capillary tubes attached to suctions. There's also Endo suctions that you can buy from other manufacturers as well. And you see how viscous the pus is. The drainage is stopped, but I want to suck that pus out. So I'll use a little mini suction tip. This is the macro cannula from the Endovac system from Cabo Kerr. Again, capillary tips from Ultradent and from other companies as well. And look at all that pus that's coming out, right? And we keep that in there. We move it up and down a little bit just so it doesn't wedge, and we can get free-flowing vacuum pressure coming in. And you can see the pus. It's crazy how much pus sometimes is in there, but the body isn't manufacturing more pus, right? And look at that. Now we got some blood coming in, and then we'll stop. We'll irrigate and dry it as best as we can. And the universal question always becomes, and I know I can read your mind, is once I've done that, do I leave the tooth open or do I close that? Yeah, if you leave the tooth open, the patient won't experience any pain, but now you're allowing it to be the conduit for like a gazillion colonies of bacteria from coming in there. And you go through a never-ending cycle of opening and closing and opening and closing. So my recommendation is leave the patient sit for a bit, because they're not manufacturing pus as you sit there. What I recommend is that you irrigate very gently, sit them up. If it's a maxillary tooth, sit them up so it drains. If it's a mandibular tooth, have their head tilted back a little bit, and then dry it out as best as you can and place some calcium hydroxide in. Then the question comes, do I put them on antibiotics? Typically, yes, they work. And during COVID, we were handing out antibiotics for infections when we didn't have time to open the teeth. But really, textbook, you should only give antibiotics if the patient has systemic symptoms: fever, malaise, lymphadenopathy, the immunologically compromised, diabetic, immunosuppressant. Those are the patients that you really want to reserve the antibiotics for, because, these are all the bad things that can happen with antibiotics. I don't have to tell you, but we still, handing out antibiotics. Some patients come in, they got pain, they got swelling. You got no time in your schedule. You give them an antibiotic. And yeah, it works. But you're looking at the next time they need antibiotics. Will it be effective? Will that same antibiotic be effective? So we got to, inform the patient of all the possible side effects. Interesting study, and I've been doing this based on this study. It's a recent study looking at using an antiviral medication in these acute apical abscesses. This was a double-blind study. That means the patient didn't know what medication they were getting, and the researcher that was handing out the medication didn't know what they were getting. That's a double-blind study. No one knew. And it's just shown that on separate studies that there's herpes virus, cytomegalovirus, Epstein-Barr virus associated with the symptomatic periapical lesions. Symptomatic. Interesting. Some things that you may not have known. And certainly until I read the study, I didn't know that. So they did a double-blind study. 20 patients they all received a 7-day course of amoxicillin, 500 milligrams TID 3 times a day for a week. Those in the experimental group unknowingly received an immediate dose of 2 grams of valcyclovir, also known as Valtrex, which is an antiviral, followed by 500 milligrams twice daily for 3 days, while the control group just received a sugar pill. And they looked to see how both the groups reacted. It was very interesting in that patients in the valcyclovir group and the placebo group were taking some sort of analgesics before they actually started the medication. In the valcyclovir group, 10% of the patients needed pain medication. No patient required medication on day 5 and 6. And in the placebo group, 90% of the patients needed pain medication on day 1, 6, and typically, you'd like more people in the group, but, the researchers found this was statistically significant and very interesting. I use it. It's a short dose of valcyclovir, and they get a rapid relief, especially if you don't have time to go in there and drain the area. Amoxicillin with that. So just a quick case for fun. Is this a root fracture? Once again, J-shaped lesion or not? We see this all the time where you see these furcation lesions. 10-millimeter pocket in the furcation. Patient didn't have any apical lesion, went to periodontist. The periodontist flapped it, curetted it, grafted it, membraned it. Patient came back about 6 weeks later to the periodontist. He still had a 10-millimeter pocket. So, it was suggested take the tooth out, put an implant in. Right? Fair enough. Patient was highly motivated, highly compliant, said, no, I want to try to save it. Dentist said, okay, well, we'll send it to Glassman. I went in, I said, yeah, maybe a crack, dumping ground, let's dump it into the crack zone. Or could be a strip perf, right? Because you don't know how deep that mesoconcavity is from a 2D x-ray, and certainly that post may be perforated out. So the patient was still motivated, so we took the post out, we did the root canal. I was sort of hoping to get that warm, fuzzy feeling that you get when you get a lateral canal going popping right into that furcation, but I did not get that warm, fuzzy feeling. I retreated it, and it was restored, and brought the patient back a week later, and boom, pocket had healed. 3 months later, complete bony regeneration. So endo perio, do the endo first. You have to have a motivated patient. You have to have a patient that you tell all the risks to, prognosis. You may end up paying for this, and we may be back in square one, and at square one, and talking about extraction and implant. All right, can't make up your mind. You're gonna love this case. Endo, implant, endo. Why does not do both? Right? Oh, by the way, the endo succeeded, the implant didn't. Crazy. This was a complaint, obviously, and went to disciplines. Interesting case. Interesting case. All right, one last case. One last case. Is it a root fracture? Lower first molar, lower second molar also previously treated. That's a pulpal diagnosis and asymptomatic apical periodontitis. The first molar had a chronic apical abscess, lingual sinus tract going right to the apex of that mesoroot. And I would bet my bottom dollar when I see cases that have been previously treated and they have a lingual pocket or a lingual sinus tract, I would go to Vegas and I would say I'd put $100 down and I would say it's cracked. And I said to the patient, it's probably cracked. You can take the tooth out or we can try root canal. I said, I can go in, I can see if there's a crack. And the patient, again, highly motivated. Take a look at the top left-hand screen. The left side is the lingual, the right side is the buccal. The mesial buccal canal was completely untreated. The distal buccal canal was completely untreated. Look at the lesion, though. Look how much bone loss is there. Look at this next one here. You can see that typical lesion there. This is a typical J-shaped lesion, but look what they actually treated from this one. Look at the bottom left image. The dentist had actually shaped and filled. I'm not even going to say clean, but shaped and filled, because there's one thing you can't tell on an x-ray about the quality of the root canal treatment, and that's how the dentist irrigated, right? It's the only thing you can't tell. But what they did do is they shaped and they filled the mid-mesial canal of that mesial root. Crazy. So told the patient, well, we can give it a try. Patient was really motivated. We took out the gutta percha. I retreat everything, by the way. Bacteria, no boundaries. I'm going to take out the existing gutta percha, and I'm going to retreat it the way I retreat it and treat all the canals. So we retreated it. The canals were already open quite wide. And interesting, if you take a look at the mesial root of the lower of the first molar, you can sort of see overlap of the mesiolingual and the mid-mesial canal. So we cleaned it out, did it, and brought the patient back. And look at that, complete resolution of that sinus tract within 3 weeks. Sometimes it occurs within a couple days. And immediate post-op, 3 months later, we didn't commit the patient to a crown yet. They didn't want to spend the money unless we were certain. We retreated the 3-7. And then a year later, you can see the lesions had healed completely. Take a look at the cone beams, pre-op cone beam, post-op cone beam. Complete regeneration of that PDL. Right? So sometimes you got to take a chance and, give the patient the option and give the patient the corresponding prognosis of the different teeth. Because, we're here, the objective of dentistry is obviously to get rid of any oral pathology and, of course, retain the teeth wherever we possibly can. So, never give up, I say. But again, with patient's consent and with, full disclosure and managing expectations is so important. So before I open up to questions, I know that some of you maybe wanted to get some more continuing education points. I do offer a very intense, it's 3-day in person, it's a hybrid course. Our course in October is sold out, but our June course is open for registration. And what we do is I partnered up with Dr. Steve Buchanan, a well-known endodontist in the US, and we send you 2 weeks before the 3-day in person, we send you an access kit, 18 3D printed teeth, a burr kit, an endo ring, some explorers, and some online instructions, and burrs, of course, online instructions to go to an e-learn, self-paced e-learn. You earn 8 CE points doing that 2 weeks before. Then you come to the Dentsply Sirona Academy in Toronto, and you are with me for intense endo training for 3 full days. It's an amazing place. It's got a sim lab. We work on extracted teeth, 3D printed teeth. We learn, actually I added a 4th system, 4 different shaping systems, NiTi systems. So if you're interested in this program, you can take your phone right now and get that QR code going. Just aim your photo over there and get a click on that if you're interested, or you can email me later on, and happy to give you some information about that program as well. But if you go to clinicaldentaltraining.com, you get all the information about that program. And many people come out of the program, have taken the program over again, because you're always learning something, even though you take the program again, and we update it all the time. What's next? You've taken a foundation endo program. I know that a lot of you want to take an advanced program. So I have teamed up with Dr. Mazen Dager, who's got an amazing institute in Hawkesbury, and we are doing a 3-day advanced endo restorative program where the first day is endo, and the second day is the restoration of the endodontically treated tooth. Dr. Dagger and I will team up, and not only do we do advanced things like an endo, we're going to talk to you about how to find that MB2, the mid-mesial canal, the lower molar, calcified canals, how to get around those sharp curvatures, how to retreat cases, how to do an anterior apical surgery. And we're going to add on some mentorship packages. So sustained learning, continued engagement is really, really important. Restorative courses will function and will focus on advanced temporization techniques, how to do post-course quick and efficient, doing it at the time of obturation, maximize predictability, and of course, maximize your productivity as well. So if you're interested in advanced course, we do have a few spots left for that. We do encourage you, though, if you're going to sign up for this advanced course, that you do have a strong foundation in endodontics, because we don't want to waste your time. with more advanced techniques if you're, still struggling with the more basic techniques. So that's basically all I have to say. I want to sort of sign off and give you my contact information. If you have any questions, I think this would be a good time. If you scan the QR code on the lower right, that will give you all my information. That will give you my social media information, all my emails, all 7,000 of my emails, my 3 websites, my office website, my clinical dental training website, and my personal drgaryglassman.com website as well. All right. So that being said, I want to thank you for all spending your Tuesday evening with me. And right on time, I'll open it up for some questions now if anybody has questions.
Yeah, that's great, Dr. Glassman. Thank you very much. I think you provided some really practical guidelines for screening patients, had really excellent slides as well. But, I really especially like the first piece of advice, which was simply to listen to patients before speaking. I think that's great advice, not only for the work you do, but for the work that we do. And it's probably just great advice in life in general.
Thank you.
All right, so let's take a look at some of the questions that came in here. This one is, do we have to freeze before gutta percha tracing?
Let me just give you my email address because I know that someone asked that. Okay, what's the question again?
All right, do we have to freeze before gutta percha tracing?
No, not necessarily. I'd say about 90% of the time I do not have to. But you get some patients that are very, very sensitive. You know those patients that go in for a cleaning, a scaling, and prophy, and you can just dig right in with the Gracie curette and they ask for more. And then you get the other patients where you just like brush their lip with your gloved finger and they jump. So I never say never, never say always. I want to get the trace. So if I have to give the patient some anesthesia, I will. But 90% of the time, I don't.
All right, the next question. How can we arrange an MSK session training? It sounds like an amazing opportunity to learn.
Well, if I can get 10 doctors, I will arrange it at the facility of Dr. Lisser at Yonge and St. Clair.
Fantastic. Well, keep us
Just
posted on that.
email me if you're interested, and I'll set it up.
Great, great. Sounds like I hope you get the interest there. Next one's a little longer. Is there a limit regarding size of radiograph and clinical apical pathology where non-surgical root canal therapy will not predictably result in healing or repair of the apical lesion?
Well, it's interesting. That's sort of an unpredictable situation because I have seen massive lesions heal with endo treatment, and I've seen the same lesions not heal. And we've had to go in and do an apicalrectomy. So I guess the rule of thumb is, the larger the lesion, the longer, the harder it is to heal. I'll just sort of say that. Is there a correlation? In my experience, yeah, I've seen massive lesions not heal, but I've seen them heal as well. So, like I said, I never say never, never say always. So hard question to answer. Sorry for being so wishy-washy.
All right, I guess every situation is different.
Correct.
All right, well, what about patients who complain about pain only on chewing, and test normal and then no consistent results with tooth sleuth?
Yeah, well, sometimes that sensitivity can be due to bruxing. So if you can't localize it, take a look at the cusp, see if there's wear on there, do an MSK screening to see if perhaps they are a bruxer. And I've seen lots of patients in that particular situation where they've had more than one tooth being sensitive and you couldn't localize one, and I'd taken a tooth sleuth and a Q-tip and I couldn't isolate, a sharp shooting pain. Often fitting them with maybe a night guard, maybe not be a bad trial and error, probably the most conservative thing to try.
All right, we have another request for your email address. Maybe you can just mention it again, and Jake, if you can post that in the chat box.
Yeah, I just wrote it in the chat right there.
Oh, okay, great.
Or Jason did. Yeah, I did it, and then he did as well.
Perfect.
Real easy. GaryRootCanals.ca.
That works too.
If you email me, then just identify yourself that you took the TMFD Dental Academy webinar, and that way I'll know exactly who you are.
Fantastic. I'm sure.
Send me cases if you like, pre-ops, post-ops, histories. Happy to give you my advice.
All right. Fantastic offer. That's great. Thank you. And it looks like that's the end of our questions. Jake, have I missed any there?
No, that's all I have on my end, Chris.
Right. Well, then I would like to thank you, Dr. Glassman. Thanks for sharing your incredible knowledge with our dental community. And I hope your colleagues were able to gain some new insights into approaches for these endo procedures.
Awesome. Thanks for inviting me.
Yeah, fantastic. So again, I'd like to thank everyone for joining us this evening. We hope you enjoyed it. In the days that follow, a video recording will be posted on our website, tmfd.ca. You'll also receive a brief survey asking how you enjoyed tonight's presentation, so please share your feedback. And please tell your colleagues about TMFD Dental Academy. We'd love for them to join and gain from the collective knowledge to be shared. Final reminder that PACE credits will be issued within the next 2 weeks. And join us again for our next webinar, which will be on Tuesday, November 12th, with Dr. John Zarb. Dr. Zarb's presentation will focus on same-day implant prosthodontic solutions. So as we close up, I'd like to thank our speaker, Dr. Gary Glassman, for his valuable expertise and insight. And thank you to you, our guests. It's been really great to share the evening with you. We hope you found it valuable. Thanks again, and have a good night.
Have a good night, everybody.